Aesthetic Association and Ilamed. Also, ex-South Zone Coordinator of IMS. I now humbly invite all the panelists to please proceed towards the stage. Dr. Jayalakshmi ma'am, Dr. Alka Jauhre, Dr. Nutan Narayan, Anjana Chaudhary, Dr. Swapnil Wilson, Dr. Sushma Ravi, Dr. Pooja Curry, Dr. Surbhi Saini, and Dr. Zainab KP. We welcome all of you to our extensive panel on sexual reset, GSM, libido, and relationship realities. I now request Dr. Meenakshi ma'am to please take over the dais.
You can also the third line. यहीं से करना होता है ना present. Full screen यहाँ पे होता है दिखता नहीं है किसी आपको फॉलो फिर करना इसको फुल स्क्रीन हो जाता है लाइवली हो हाँ हाँ ये ठीक है फुल स्क्रीन करते हैं इसको यहाँ से फुल स्क्रीन इसको करूँगा तो ऐसा ही होगा बहुत सिंपल होता है सब करते हैं ये मेरी है यही है इसको करेंगे so by the time they're going to be doing it, so on behalf of moderators, experts, and all the panelists, I wish to really thank the whole Raipur of the Menopause Society for giving us this opportunity to be able to really discuss and talk about a subject that we do not much speak about. So a very warm welcome to all our experts and our panelists. And I hope we're going to have a great session learning from each other. इसी को फुल स्क्रीन कर दो ना यहाँ से फुल स्क्रीन कर दो इसको क्यों थोड़ी आंखें ना थोड़ी कमजोर हो गई भैया that's okay. So I would just like to start with a few words. We all know that hot flushes, night sweats, that is what is synonym with the menopause. But they fade with time. Genitourinary syndrome of menopause is very different. Our Indian social registry says that nearly 65% of Indian postmenopausal women suffer from GSM, yet we do not talk about it. And the difference is that it keeps increasing with age and it does not improve without treatment. So, what is the aim of the panel today? We need to break the silence on this condition. We need to find the solutions both for ourselves and our patients because this condition impacts the quality of life, it impacts the intimacy and the daily comfort of millions of women. With that, we start with basic, very simple presentations. We slowly will build it up. We all see it every day in our lives, so we're not expecting anything extraordinary, but just our experience of how we tend to manage. So now there's this lady who comes down to you. She's taken a long time to come back. She sits very hesitantly in front of you. She says, I feel so dry down there. It feels as if it is on fire. I put a lot of ice cubes to make it much less, but nothing changes. So this lady is about 58 years. It's been 8 years since she's menopausal. No other comorbidities. She says she leads a good lifestyle. She takes multivitamins. But for the last 4 years, it's been progressively increasing. And for the last 2 years, she's going through hell. So we did an examination and we find that the vulval fat is much reduced. It's very thin. It's pale. Looked at the introitus. It was very narrowed. Could not put a speculum inside. We could just see the rugae and a few petechiae. So the question that I would like to ask our panelists is, you have a very busy OPD. There are a lot of patients. Predominantly, you're seeing vaginal discharges or maybe pregnancies, and this lady comes and sits in front of you. How much time do you think you'll be able to give her? She's not speaking very openly. धीरे धीरे बोलती है, बहुत time लेती है. So, how much time do you think you can give it to her?
Ma'am, we have to give them sufficient time so that they can express their symptoms. Sometimes either they don't know or they are hesitant about the symptoms. And sometimes we have to take them in the confidence that this is not just a untreatable disease and we can treat them easily.
So this is one patient that you should not push out of your OPD. You should tell others or your person who's managing that you need to give her time. And I think 30 minutes is a minimum that they will take
We can
when
make
this?
questionnaires also for that.
Yeah, we can do that also. So 30 minutes is minimum, I feel. When they come in, you should realize कि अब 30 minutes लगेगा, चाय मंगानी है, चाय मंगा लो, कुछ भी मंगा के बैठ लो, but don't hurry up at that time.
I would like to add one point. I slowly signal to my nurses that, it's going to take time. Don't rush.
Yeah. Yeah.
So that we will be able to do full justice to whatever she's
She's
doing.
doing. Yeah.
And privacy also matters, because if anyone is there, like sisters are there around us, so they are not very easy to open
Comfortable
up.
to talk to you.
Yes, so if they want to say something about their sexual symptoms or any other personal things,
Yeah.
so they'll hesitate.
And sometimes we have to ask leading questions also.
Yeah, that we'll follow it up later on. So the just concept was that give them time. That's most important. And as you rightly said, I'm a little strict gynecologist. So everyone knows when a patient is there, no one can enter my room, whether it's a GDA or it's a nurse, because privacy is something that's most important. Okay, so I've basically given some history and examination. Do you think that's enough? Or you would like to ask something else to be able to label her as a GSM?
Just by history, I think, we have
Well,
we have
I've just taken
reached-
history of vaginal dryness and that.
Yes.
So anything else you would like to label her as a
Examination.
GSM?
Examination.
And in history, maybe something about urinary complaints.
Yes. After the history,
Yeah.
then with the extensive history, all the drug intakes, the urinary symptoms,
Yeah.
the dryness, and when is it more?
So that will be there. And a little sexual
Sexual
also.
symptoms.
Yeah, that is also, that's very important.
Any
the
hospital
guideline-
bleeding and dyspareunia, we have
Yeah.
to ask.
So you need to take all the factors, genitourinary. So we are talking of dryness, we're talking of sexual, we're talking of urinary, before we can label her at to this particular
And
one.
only
And in
history-
examination, what would you think? Are we able to do a PS in these patients? Can we put in a speculum?
No.
It's very painful in that case.
Yeah. So what would
we
you
have
be
to
doing
use
for
a
such
small-
patients?
Sometimes the introitus is so narrow that you cannot even insert one finger or even
Yeah.
two fingers, even if you want to do a finger examination, PV. And speculum is a big no-no.
Yeah. So
Patient
you
is
have
not
to be
going to
very
tolerate it.
soft.
Yes.
Tell the patient, if you have little pain, I'm going to remove it. And sometimes even you need to have a lot of lubricant. You need.
I think basically they don't like the internal examination at all.
Yeah. Yeah.
First of all, they refuse. So convincing for that examination also takes some time.
Yeah.
And then we have to proceed as it is convenient to the
Do that.
person,
Yes.
to that lady.
I don't think we should push her for the internal exam.
Exactly. So
It's
we can
visible
always
from
say,
outside only by
Yeah.
looking at the
Just
vulva.
separating it
When
only
it's
you can see.
atrophic and pale and there is
Yeah.
petechial hemorrhages, something there, then we can understand it is atrophic.
When you're examining her, it's a very good excuse. That time, when you say and she says, no, I'm not comfortable, then you say, are you comfortable during sex?
Yeah.
This time she's come up that no, we've not had sex for the last 3
Hmm.
years or 4 years or 5 years.
exactly.
So the examination itself, it's a very good opening this thing, because then you'll see that she'll just come out as a deluge that this is the problem.
So we've gone through our latest IMS guidelines, So we used to think GSM is just about there. So they have come with a particular criteria. So for diagnostic criteria. So anyone could talk about the criterias that are there with this.
The latest IMS guidelines say GSM needs to have three characteristics. That is the vaginal pH, the VMI, and then the most bothersome symptoms.
Okay. Right.
At least 2 urinary or genital symptoms should be there. And we have to exclude estrogen deficiency in that.
Other
And
causes
second
like
one
lichen
is
planus.
one symptom with
dermatitis.
pH more than 5. Though pH is not essential for
Yeah.
the diagnosis.
So I think this is the first guideline that I saw which actually came out with the criterias, because otherwise we always used to say.
Yes.
So it says at least 2 bothersome symptoms, can be urinary, can be dryness and anything there, or one symptom with the pH. So about the pH, if anyone would like, भैया बैटरी खत्म होने वाली है,
अभी तो दिन शुरू हुआ है भैया
इसको कुछ करो. And so vaginal pH, when we're doing an examination, does
Maybe
anyone of you do a
menopausal
pH?
Vaginal
That
pH is not
laptop also menopausal. Estrogen should be
Early
given
morning.
now.
बैटरी शुरू होती है
No, estrogen should be given now.
So anyone does pH?
it's not routinely done.
You
because
do a routine pH?
So all of us should have this vaginal strip test. It's very cheap. It's available on Amazon. So it's like a reel. You just have to take one
Strip.
2 centimeter strip of a paper keep it in the vagina and wait for some time. If it turns green, it is alkaline. So you can compare it with the color coded strip on the box. So it's very, very easy and economic. So by looking itself as an experienced gynecologist, you can make out whether it is pink or pale, it has a rugae or flat, or if there's any dryness. By seeing the mucosa itself, you can make out, but you should have evidence, right? So that's the simplest test without going to the lab, can just show them. For yourself, you'll have that. But more than 4.5, obviously it is estrogen deficiency.
Yeah. But does it affect your clinical practice? Because if you're having a look at the vagina and you know it is there, it just corroborates, probably underlines the fact that she has VA. So if you don't even have a strip or you don't do it, but I think the treatment can still be started.
Yes.
Yeah. So that's about.
But nowadays,
Everybody's
wants
asking for
ask
evidence.
What is it right? Are you doing the right thing? So special. Yes, exactly.
Yeah.
So this is small thing and it doesn't take much time. Maybe 2 minutes.
That can help in like having the research or papers.
So it's available on the Amazon, that you're saying that it's available on.
And I think especially with patients Googling and doing an AI research before coming into our consultation rooms.
Yes.
So probably
Yes.
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 Yeah. So definitely it says, although we don't need to treat the paper, we need to treat the patient, but it is a good clinical diagnostic tool. If we do have it, we should be using this particular one. But what about VMI? That's the vaginal maturation index. Do you think that should also be done in case of VVA in a clinical practice?
Actually, it's not needed for establishing the diagnosis, but yes, for research purpose or if you're doing any like study, then
So
you
in
can
clinical
include
practice,
that.
doing a VMA is obsolete.
Yes.
It's not to be done. But yes, it has a major role as far as the drug companies are concerned, because the effectivity of any method is dependent on the VMI, whether it improves or it doesn't improve. So
Or
that's,
also
vaginal health index also.
yeah, both the things
pre
can be.
and post lasers.
Yeah, lasers, or probably when they did the vaginal DHA or when they did the osmofene, that's the way they found that it's found to be very effective. So, but for us in clinical practice, I think history taking, examination again, don't force yourself, be very soft and kind with them, and doing a litmus paper. So, I think when we can't do a pH at that particular time, just putting a litmus paper to be able to find a pH will be able to corroborate our findings. So, that is where we keep it at the examination point. So now we just move on to the next point, and that is, now we have diagnosed, yes, she has GSM. So what is our strategy? So how do we go step by step in that? Zainab, what about you?
Madam, we should counsel her. We should say that it is a normal process in the process of aging, unlike vasomotor symptom, which
Fade with time.
yeah, which will fade with time. This, as we move on, it is a chronic deteriorating thing if we won't treat. So, treatment is essential.
Yeah. And I feel if we tell them कि ये तो aging का process है, people start feeling old.
Yes.
That it is a part of your aging. We don't need to tell them. We need to tell them it's a medical condition which anyone can have. And we have treatment and you'll become fine with it. I think that's the way we need to, कि hormones कम हो गया, age हो गए तुम लगता हम तो बूढ़े हो गए. That's why it is. So that concept or the misconception we need to remove.
So while counseling, we have to explain them that it is gradually progressing disease, and we have to stop it or we have to control it at early stage, so that it should not increase the symptoms.
I think that's where the awareness needs to be spread, come early, so that the
For
effects are going to
by
be.
lifestyle modification.
Yeah, that's on there. So I think, and also to tell them you're not alone. Everyone feels I'm the only one because you don't share it with anyone. So if you tell them 70% of women are going through it, then they feel, yeah, I'm not the only one, right? So that gives them a lot of confidence.
Especially when we include ourselves also, they'll feel very nice.
Very nice, yes. So attach your story to their story. I think
Yes,
it
we
will
can
be.
add our story.
Yeah.
And the best thing is that when we tell them that this is normal, then they say, "अच्छा और लोग को भी होता है?" I said, "Yes, yes.
And
People are getting it."
doctors को भी होता है.
हाँ, doctors को भी होता है. आपको sometimes not everybody doesn't ask आपको,
Yeah, directly.
but they do say doctors को भी होता है. Yes, everyone, all females, they are all the same boat. They are all going through the same process.
And I
That
think
is the
appreciating them that they come to you also is very important because it
Yes.
takes a lot of courage to come and sit across your table and to be able to speak. So be a very good listener. If you're a listener, they'll start opening up instead of asking
Yes,
direct
yes.
questions, and then tell them thank you so much, or maybe appreciating you've had so much courage to come today to me. It's very nice for you to do that.
Encourage them to send their friends.
Friends also.
Practice words. Marketing.
So if anyone who has not yet spoken over here.
Your best advertisers, more than social.
So when such a patient does come and you assess, शायद ये hormones नहीं लेगी. Many times you can assess by the body language, right? So what is the first line of treatment that you would like to give? Anyone who hasn't yet said anything?
Non-hormonal treatments should be the first line.
Should be the first line, or you
yes,
feel it?
because you have to assess them for acceptability of hormones
Yeah.
and rule out other comorbidities also.
Yeah.
So that itself is a big thing. So
But
for
after,
now,
there's a reason why you would not give her locally.
no, ma'am, I will take
How
time
much-
to assess her for that. Until then, I can put her on non-hormonal treatment or supportive.
in the first
Yes.
Okay. So
first time students. But if it is not acceptable or you are waiting or she's waiting, then probably you should look at that.
so what are the non-hormonal you write?
First line treatment.
On the severity of her symptoms.
Yeah.
If it is very severe, the first line, we have to convince them something that the first line is hormonal treatment. If it is not that severe, if they are not very in favor of it, then we can go for lubricants.
So what are the non-hormonals you use?
Actually,
Is
we
it
have a
available
lot-
in the market?
You know, there are a lot of things available in the market, but I read somewhere that coconut oil
Yeah.
is supposed to be the closest to the vaginal discharge that we have. I mean, that is what secretion. That is what I read.
Okay.
But I tell them, I give them the vaginal preparations, but I tell them that you can also use that. And well, gives quite good results.
Yeah. So what's the difference between lubricant and a moisturizer? Anyone?
Moisturizers are for the dryness, and
Okay.
lubricants are specifically for sexual intercourse.
Yeah.
to
So lubricant
facilitate
has
that.
to be used
Yes.
at the time
At the
because
time or
patients
30
get
minutes
grossly
before.
confused. कि moisturizer and lubricant hai. So what are the moisturizers that are available in the market? Are there any available?
Hyaluronic acid based moisturizers are there.
Like?
They're very good. One is available on Amazon, Sephora करके है, and it's very good. Cheap also, and good acceptance.
Any other one anyone is using? Any other name?
Thirsty cream.
Which
Thirsty cream.
Thirsty.
Green and
Hyaluronic
pelvic
acid.
gel.
Yeah. It's a medical grade one.
Mhm.
It's affordable.
Yeah.
And it works very well.
And
Even
you give
for
it.
the external genitalia.
That's for external, but for the vaginal, I think.
Placentrex cream. I watched Placentrex gel.
Yeah. Yeah.
Now they have come up quite the vaginal gel.
Yes. Yes.
And there's repellents, you can get it on Amazon. That's also available. It's a little expensive, but that's another thing that's available onto there. And previously we were having the isoflavin based also the moisturizers. And one of the companies had brought about it was known as the Isrin gel.
That is
Pelvic gel.
DHEA.
DHA is unfortunately we don't have, but that goes in the other one. But as far as moisturizer, Isrin, I found myself very good patient's response with that, giving 2 times or 3 times a week. But it's gone off the market. Probably we don't write. So that's where.
OTC products also, ma'am, like Pond's Light. It's hyaluronic acid and vitamin E gel. It's available everywhere on the counters.
works.
And there's one from Vaseline. Vaseline brand. It has a hyaluronic acid and vitamin E gel.
But they're all for the outside.
Yes.
Right.
You can apply inside also. No.
Okay. That's an off-label use.
Off-label.
That's enough.
That Ectode Ka local has come out with a
Yes.
yes.
Now I think pelvic gel already
Even
there.
Yeah, that's also okay. But 2 or 3 times a week, I think that would be good enough for these ones.
There are L-arginine combinations also.
Mhm.
L-arginine combination with hyaluronic acid in
Acid.
the market.
Okay. So it would be really nice if you could put them on the group that we are on so that we all also right?
With the names, yes.
Kepler brand.
Yeah. So now we come to the main area, and that's a vaginal estrogen. So I think all of us are using the vaginal estrogens. What are the names of the vaginal estrogens we use in the market?
Avalon is trial
And
cream that
That is
Premarin.
estradiol, right?
Yeah,
Premarin.
conjugated
Premarin.
And Premarin, that contains.
conjugated equine estrogen.
Conjugated
So which is considered to be better?
Actually,
Conjugated
estrol is
Yeah,
low
so-
potency.
Yeah, the estrol is a low
Estradiol
potency.
is the best.
But we have now over here. I just want to make a comment. The estradiol that we have, the estrogel or the estrabet gel, that is only for transdermal. So many of the people I came to realize that they're using it even vaginal, but that's not the potency to be used vaginally at all. So it is only the infertility ones who can afford to use it internally. But for a patient who's postmenopausal, unfortunately in our country we don't have a 17 beta estradiol gel for the vagina. So we have only estriol, which is a little low potency, and we have Remeron. So any special instructions you give for your patient when they do it? This is how to use it. Anyone?
Correct
So
dosage should be given. There's an applicator given, and it should be inserted only on the outer surface of the vagina, not given too much deep inside. Those are the instructions written there. And about the dosage, for 1 week or maybe 2 weeks, we give it every day, and then it has to be tapered down for twice or thrice in a week.
And you can give it up to?
Up to 1 year, it can be given, but you need
Evidence
replacement.
till now is
Yeah.
still 1 year, but you can take it for much longer period of time.
the effect will last after like till 1 month, maybe after stopping the treatment.
Yeah. So many of them take 3 months, they put off, then they come back after 3 months, then to do it. So anyone in your experience, anything special you share with the patient when they have to apply this applicator? Because the applicator is a little,
Yes, it always injures the
yeah, it can
mucosa.
injure at that
Yes,
particular
yes.
time. So we have to be telling them to apply something prior to pushing the applicator, not to go too deep. And there's a red mark on that. Till there only you need to fill it up. And you need to wash it and keep it. What patients don't do is remove plunger, wash it up and keep. Otherwise, it will all keep getting soaked. So they need to keep it very clean.
So I tell the patient, worried about that plastic thing going inside, then measure it and put it on your finger.
Yes.
Then put it inside, and since there are fewer, but there
Keep
are
it outside.
outside, put the rest, जो बचेगा उन्हीं के vestibule में अपने लगा देना
Yeah.
अंदर, so that little response comes
True.
inside also, and inert
Ac-
most of it is.
Actually, because of the thinning, that helps a lot. with
Because
the-
outside
yeah,
dryness, vulval dryness is huge.
thinning and
So small
dryness.
bit can be, but I've generally seen when you tell them to apply initially outside, they have a lot of burning because that particular area it absorbs it. So with time, I think it settles down. But initially, you may tell them that you may feel a little burning, but just wait it out. It's going to become
There's a
right.
study
Yeah.
that you can apply it on the mucocutaneous junction
Mm.
once in 15 days. You can use lifelong.
Yeah, because the absorption will be
Uh,
even.
We can, just to avoid symptoms, you can start it around perimenopause, before menopause, and you can continue it forever.
Yeah. Yeah, but still, guidelines have yet to take it on.
Some
Studies are coming.
Some studies are.
Yeah, that
Of
would
course,
be good.
local, of course, is quite safe. It's considered quite safe.
So we don't need a surveillance.
Mucocutaneous junction,
Yes.
the ring of fire, as they
Mm.
call it.
Less of absorption, even less
The mucosa.
mucosa. Yes.
So do we need to do any transvaginal ultrasound, any surveillance with these, whether the endometrial thickness is getting big?
Actually, we do not.
Do not.
Not need.
It does not have much effect on the serum estradiol level. So
So that is one
it's not
point we
required.
need to take, that we do not need to do any surveillance for these patients. Progesterone does not need to be added. We can give it in the particular dose for a longer period of time, but important point, tell the patient to come back for follow-up. They get very well and they do not come back to you. And we've known patients who've been using it for 15 years non-stop. And when they did come back to us after that, we got an endometrial thickness of about 10 millimeters. So please, in your prescription, a follow-up is most essential to be written over there. Otherwise, you're medico legally liable that you have not written for a follow-up and you did not advise that particular patient onto them. So I think we have already covered these. These are the two creams we are talking of. So we are looking for the vaginal DHEA to come. Anyone uses any of these energy-based devices for GSM
Yes.
as
Yeah.
a second line,
Second
Yeah,
line.
as
a
a
second
second
line,
line,
not as a
not as
No.
a first
not as a
line.
primary. I hope none of us are
Yeah.
using it as
For
a primary.
SUIs, if they have all the like 2-3 symptoms, basically, then we can counsel them. Like for in starting, you can use this, and if it doesn't work, then we can go for
So because
lasers.
at present there's not much of evidence to say that this is the one. So it is off-label, off evidence, but always the second line, never
And
as
yeah,
a primary line.
yeah. And
So
here I want to add
Yeah.
that evidence we can create ours in
Yes,
our practice.
exactly.
So if all we gather and have
Yeah,
the
have that
energy-based devices, we can create our large
I think in
evidence.
that way, I would
Huh.
really like to congratulate the IMS, because IMS really works hard to create. Of all the societies in India, I think this is the one society which is so academically oriented to do that. So, for the first case, I would just like to end by saying when we treat GSM, we are not relieving just the physical symptoms. We are actually restoring a woman's autonomy, her self esteem, and her overall well being. So, let's not leave it at that. So, with the next case.
At the outset, I'll request the hall in charge. We had 20 minutes for discussion. Please add it to the panel time only, because I think we are doing a very good discussion here. I'm sure everyone is benefiting from it. So coming to the next case, if the hall in charges are not listening. Bhaiya 20 minute और दे दो. हाँ. So severe dyspareunia and sexual dysfunction. So I just don't want to have sex anymore. And when we go down there, it hurts. So like I said, sometimes a patient may complain, and sometimes when you're taking just come for something else and you're taking the history and this turns out, or for me, the easiest way when I feel that she doesn't want to broach the subject, when I put in the speculum, I'll just say, when did you last have sex? Which she'll say, is this going to hurt? I said, no, it's not going to hurt. When did you last have sex? So she'll say, not for the last 5 years, not for the last 6 years. And then I'll ask her, but why? Because sometimes you must realize there might be a religious connotation to it. Sometimes it might be the male partner. You know, men's libido also goes down. Their performance with diabetes and all in our country goes down. And the woman must be just not having sex for that reason. But mostly they will come up that I don't feel happy about sex. So that's where we need to be thinking about this, because sexual dysfunction affects 40 to 60% of midlife women globally and is even more prevalent in India. And here I want to make a point, because I'm very happy to have young panelists on our board, that, I always believe that old is 15 years older than we are. Please don't think women who are 15 or 20 years older than you are not entitled to have a good sex life. It's a message you must all take here, that it is very normal to have a good sex life, even in your 50s, in your 60s and 70s. Please don't judge women for that, and don't think that, no, they shouldn't be having a good sex life. So, sexual dysfunction affects 40 to 60% of midlife women globally. It's even more prevalent in India, 66 to 80%, especially because I think we have an earlier age of menopause. So we see more of that with a better life expectancy in women. So we need to take care of that. So she's come for a regular checkup. How would you approach her to be able to get this line for her? And how do you assess the sexual health of any woman? Are there any new assessment scores, especially from the 2026 guidelines, if someone would like to elaborate?
Just like you said, when you're examining, then you can put a leading question, just like you said. Also, while talking casually, also we can ask that some women of your age do not find it very comfortable to be intimate. So, is it affecting your life? Is it happening with you? So, all those things are there. And then this score, FSFI 6 score, this is female sexual function index. This is a very good score, and it's very easy to understand. Revolves around six domains like desire, arousal, lubrication, orgasm, and then satisfaction and pain. Mostly patients give the highest score in pain. Orgasm, most of the females do not understand. And satisfaction also they do not want to comment on. They give full marks for satisfaction, but pain they give a lot of points.
I think here the take home message would be to all of us to be comfortable using the words orgasm, using the word satisfaction, talking about desire, talking about arousal. These are things which, leave alone menopausal women, I think we hesitate to talk about for any woman, which is very unfair. Her sex life and satisfaction is as important as a male's. And whenever a patient comes to you, these are terms that we should be comfortable using in our clinics, in our talks, even when we are having, public awareness gatherings. Please learn to use these terminologies. They are not bad words. So that's one thing, so that the patients are also comfortable talking about it. And like you said, they don't talk about orgasm, they don't talk about satisfaction. Why? They should. So that's something that we should be open about, and we should encourage them to talk about it.
We can keep the leaflets like of this questionnaire in the
Yes.
OPD,
Yeah,
so that
sometimes,
they can fill it up by their own, and they'll
Yes.
come up with their problems.
Absolutely. So these are there. We have them in
We
the
do keep
guidelines.
it.
You can get them printed. You can keep them in your OPD. Keep it part of your menopause book. The patients can also mark it, or you can mark it. So depending on the people that you have, the sort of patients you see, and how comfortable you are. But that's what the message was, that all of us should get more comfortable talking about it.
Most of the patients come for some other reason, like
Bilkul.
recurrent UTI, dryness, itching, all those things, vaginal discharge and all. So in the first session, I usually don't talk about all this. I just give them a hint that if you feel okay, you can talk about this in the next time. When you come for a follow-up after 3 days or 4 days, mostly patients open up in the third session with me. And because maybe it is because of the age gap.
Yeah.
And I would really like to say that most of the patients, the young girls who come for MTPs and their vaginal discharges and all those things, they come and tell me it was very comfortable talking to you because we have that age gap and she was not comfortable with talking to some other senior doctor. She has already given a visit. So this is ulta with us when it comes to these things.
That's why when we are younger, we wear saris to the OPD and later we wear pants.
I think we should not be judgmental.
Yes, yes.
That's most important point.
I think the beauty is assessing your patient. That is all. I think knowledge, everyone has 90, 100. है. किसी की knowledge and surgical skill में 80, 100 होगा ज़्यादा.
Yes.
It is how you assess your patient and how your communication skills
I
are.
want to tell you one thing, Meenakshi. I had a patient who was 65-year-old, and then she came with a complaint that we still like to have sex. And her husband walked away. She sat with me and she said, but without any hesitation, she asked me, is it okay? Or is it, okay to have pain and all that? I felt so nice. At least they're enjoying at this age. And I always tell others, see, a lot of women do enjoy, but then why you people don't want to enjoy? So
Very
that is,
true.
I think we have to.
I think when we, considering that at least I am 60. So when I started practice, I think, at that age, at 18 and 20, we were not talking about sexuality also. So if 18 and 20-year-olds can talk about it, we can jolly well talk.
Yes.
Also, once they come in for the consultation, the attender walks out,
Yeah.
and then
You,
near the door, then they come back.
yeah. That happens very often, that when they're
Yes.
leaving, they will come back.
They will hesitate.
Yes.
I just want to ask one question. This orgasm and satisfaction, females, they sometimes they come and say that जैसा उनका गिरता है ना हमारा नहीं गिरता है. They are not having orgasm. And that orgasm is not natural in a female, I think.
Yes. I think the men have to make a
Extra has
little
to be done.
effort.
हाँ. Important foreplay. Yes.
Also, I think sometimes, like she said, that sometimes, there are women who've never even experienced orgasm.
Yes.
So also here, I think in the history, you have to be technically little this thing, that is it different from what it was 10 years back? Because that would actually show that, yes, there's a difference. There are women who are never interested in sex also, to each their own. But the difference in all of these also should be talked about very
I think
clearly.
now this Gen Z population, they come up.
Yeah.
Okay, I am not able to
Oh,
enjoy.
I've had,
Why?
I'm digressing. I must tell you that there's this girl who used to come with her boyfriend or something. And then when she came with the guy she was getting married to, and she came in 5 minutes before and she said, how do I tell him he's not as good as the other one? I said, okay, like, I don't know how you've come from premarital counseling. I don't think I can talk about, till you bring up that, okay, I don't get satisfied with something. How I can't bring it up now.
This is a critical situation for us.
So, what do you think are the main reasons for sexual dysfunction at this age?
There are many
Vulvovaginal atrophy that makes the vaginal orifice narrow, and it causes pain also because of atrophy. And we down there in vagina there is less lubrication, so that is also a problem. And she feels dyspareunia because of
So,
that.
if there's pain, she will dry up immediately.
Yes.
So, the next time, even the thought of a sexual encounter, even if there's been enough foreplay, she might dry up. And that's where I
Secondary
think
vaginismus.
lubricants and all help. That if she's comfortable during sex, she might be happy having it, and then she won't need the lubricant also.
And that
Like
leads
add-
to low desire.
Yeah, absolutely.
Yes.
That elasticity
secondary.
also compromise.
Partner communication is also important here.
Yes.
Partner problems with the partner communication. The man doesn't wanting it, or he's very quick, not doing enough foreplay. All those things are very important because the female is not able to explain to him what she wants, or she might take time.
Men have a lot of comorbidities. They may be
Yes.
hypertensive, they may be on various drugs. Their erection, their ejaculation is also affected.
Even other conflicts also reflect here.
Always.
The
For women,
social.
sex is more in the head. For men, it's down there. For women, it's up here.
Exactly. I would add one thing. It's time. Nobody has time for sex nowadays. Everybody's busy making money.
I agree.
They hardly have personal
Yeah,
time.
maybe about 20 years back in my OPD, not again for menopausal women, but even earlier, 30s, late 30s, 40s, the men used to complain that, my wife doesn't want to have sex. Now it's the women who complain that the men don't want to have sex and we have a lousy sex life because the men actually are too busy with, stressing about work and otherwise. So I think we've covered this. So your clinical approach, I think, aap boliye.
Madam, first we have to treat the pain and then evaluate the libido, inquire about the partner and target the libido.
So little detail, if you would just quickly go over it. So we have to also confirm that, even if everything looks okay and if the libido is not there, so that means that we need to look at that also. It may not just be the dryness which is creating problems. So mental health and those issues also need to be kept in mind. You
When
want
we
to
are
add something?
when we are treating the pain, we also have to do the examination and see whether there are any infections there.
Yes, yes. So vaginitis, atrophic vaginitis and all can also be the
Even
reason.
lichen sclerosis or
Yes.
itching, recurrent itching or irresistible itching can cause more of secondary infections.
50% of the cases are solved if we remove the pain.
Absolutely. So, what pharmacological treatment would you recommend to her? Are the pharmacological treatments sufficient? And what non pharmacological treatment would you recommend? One point here, I think earlier we were talking about lubricants and moisturizers being enough. But please always keep in mind that even that you use, like if patient is resistant to estrogen cream in her head, not locally, you must talk about it from the beginning that that is the definitive treatment because we know that this is not going to get okay and it is a progressive thing. So even today, if it's mild, which gets okay with that, she should be mentally tuned that at a later time she is going to have that issue.
So
So that it's not
counseling,
that I'm not giving it to you because it's harmful, but maybe later we
yeah.
will
So
reassess.
counseling and our confidence is the first point that they should have, that yes, it can be treated, and we can start with the medicines
Yeah.
or
So what
non.
medicines would you recommend?
So first will be, as we know, low dose estrogen. If she's having any pain, we can add on the anesthetics also, and counseling. Like you can go slow. First, heal the lesion or decrease the dryness or atrophy, and then you can slowly go on with the trying with it.
In one
Serial
sentence.
dilators can be used just like we are treating
Serial
vaginismus. It
dilators.
is it is a condition of secondary vaginismus we can call. So serial use of dilators just to build her confidence, pelvic floor physiotherapies, and then couple counseling is also
Yeah.
important.
So also
You
when you're talking about dilators, I think you should get them tuned that using a toy is not a bad thing also because those are more women body friendly compared to just the dilators we get on Amazon. So
Masturbation by itself
it's a very good exercise.
Increases the
regular.
blood flow. So sexual activity itself is a helpful to treat.
Or but if they can't do it, at least start with masturbation. I think this point we have to tell
Yeah.
whenever women
I
comes
think
to us and they get these dilators with masturbation and all.
yeah.
So they can try it out.
So the sense of shame with dilators and masturbation needs to be removed from at least up menopausal women, if not
So
everyone.
here I want to add on, like I have seen many patients, they had urinary incontinence, especially stress, and at the time of intercourse, they would have that incontinence, and then they would feel ashamed,
Shame.
and then they stopped having
Yes.
intercourse. So addressing the other things also with lasers specifically, I have seen that made a wonder.
So one last line on on oral estrogen therapy for this, just if anyone wants to make a comment.
Would you like to give it?
Oral estrogen.
No,
Good.
no.
So pharmacological treatments for decreased libido.
If all the other things are taken off, then we can give systemic testosterone therapy, although it is not approved.
What is
for
anyone using? Practical points for
no.
the audience.
Androtest gel, we can
testosterone gel, but remember to use 1/10 of the male dosage. So that's something very that testosterone.
Because you have it only for infertility.
Yeah, you have gels as well as sprays available, plus but use a very low dose. And also testosterone causes aggression, so you have to see that that also doesn't happen.
And reevaluate her every 3 to 6 months.
Some patients in their 40s, late 40s or mid 40s, they come with ADDI. On the internet, they see ADDI is there,
ADDI,
and can we use it because I have low libido.
So that is an FDA approved.
Yeah, ADDI is FDA approved. And what about Tibolone? We always have we've been taught all these years that Tibolone really helps in libido, but the 2023 Cochrane review says that effect is low or certainty and does not demonstrate a significant benefit over placebo or standard MHT. But I think clinical experience for all of us has shown
It is a
but
good.
that's what the literature says.
It's
That's
good
the
for a
latest difference.
non-hormonal treatment for MHT. Like
Yeah,
otherwise, we can have that.
and local
It
definitely.
helps in other ways too.
MHT systemic, then transdermal is always better. That has a much better effect on the sexual function.
Any new drugs coming in?
That's what you talk about.
ADDI.
ADDI is one. Hopefully.
ADDI is there, Vilacy is there. So these are things that we are waiting for, looking for, and if anyone wants a reference, they can take it. Although most of this is from the 2026 guidelines. So pelvic floor physiotherapy, dilator therapy, and sex therapy necessary to address relationship strain, manage performance anxiety, and temporarily shift the couple's focus towards non-demand intimacy and sense-safe exercises.
Exercise, I think that like improves a lot. Any form of exercise, yoga, exercise, or whatever you do.
So you have a 20 minutes more for discussion also?
Yeah, that was 40 minutes plus 20. Look at the 1 hour. Yeah,
Did we have 1 hour?
Yeah, that's what carrying.
Okay, so we have discussed the main parts. So we have already discussed the main parts. These are small little things that we are going to be discussing now. And this particular lady, she has severe vaginal itching, burning, thick discharge for last 3 weeks. She keeps scratching and she keeps scratching, and she's got the thick, curdy white discharge which tends to stick to her. So that's what we saw. It is totally excoriated. Their thick vaginal discharges, and it's candidiasis, right? So how would you, in a postmenopausal woman, is it just the candidiasis, or do you think something else? And how would you diagnose, or what extra would you do for this patient? She's hypertensive. She's not a known diabetic. So what investigations would you like to do?
I would first investigate her for diabetes.
Yes, that's important. So you do her HbA1c, you would do her sugar
Fasting
levels.
sugars.
And what about the pH paper in this? We can do that.
Only to corroborate the diagnosis.
Yes, that it is candidiasis. All the PS we've done, we've seen thick curdy discharge, we've done that. And it's
Culture, ma'am.
yeah, that's important. And what were you saying?
Even vaginal culture can be done to look for mixed infection.
We can do that. And if she's a persistent candidial infection who's been having, then we can even do a fungal culture also in such case, because many of them may be the ones which do not respond to such.
Persistent infections.
Evaluated here.
Yes. Partner also. And what about urine infection also? Because they'll always have burning and everything. So we need to rule out, don't leave that out. For all you know, they may be having a urine infection that is coming. So it has to be a holistic approach that we're going to do, looking at the systemic conditions like diabetes, looking at the local, corroborating the partner we need to evaluate, and also doing a urine infection for these cases. So what is the management approach? Now, this is totally clinical. How are we going to help this woman who's got excoriated, very badly itchy? We are not just see candidates. This is what is the multiple levels of treatments that you're going to do locally. This is we all going to learn from each other because it's all off books. So how are we going to be doing?
So it can be a mix of infections plus dryness.
So no, tell me your treatment. What would you do for her? Just tell me what you would do.
So I'll just start with antibacterial, antifungal, and along with that,
That's oral. You're talking antibacterial and antifungal orally.
no, local.
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 So what's a combination? Are you going to be using a combination which has got antibiotic plus fungal plus hydrocortisones?
Plus, yes.
Steroids.
To relieve
I
the pain
think
and
first time we should not give antibiotics. It may be mixed, But first, we should give only antifungal.
Yeah, because the fungal will become worse if you're going to give the
Yes, yes.
antibiotics.
And then after that, in follow-up, we can use that.
Yeah. So we start with oral antifungals. I'm sure all of us are starting with oral.
Yes.
So it's fluconazole probably 150 milligrams every 72 hours for 1 week, and thereafter we can give it. And maybe some of us are giving the Candistat also, the one that's 100 milligrams. But then we need to rule out they don't have any cardiac issues when we are giving the Candistat, right? So that we've given an antifungal. Locally she's burning. So what are we going to do?
But here I would like to add one point. She's already taken over the counter treatments.
Yeah.
So fluconazole she would have taken fluconazole multiple times already
No, that is
before
not
coming
over
to
the
us.
counter. Is it available? So, see,
Actually, in India, everything is over the counter.
so that's right.
So you can't just say everything is over the counter. So let's say that she hasn't. She's a naive patient who's come to us. So we have started with that.
Yes.
If she's already taken that, probably you'll go on to the higher drug, which we're talking of the candy stats and all, probably. And locally, what are we going to do?
Vaginal
steroid.
or also antifungal we can give.
Yeah.
Along with hydrocortisone.
Candid B cream.
Yeah. So Candid B cream or 1%, yes, that's a combination of them. Don't have any antibiotics, I personally feel, locally. But this takes a little time. So what are the local remedies that we can tell her? Kuch kar lo, better ho jayega.
Ice packs.
Emollients, ice packs.
Coconut oil, as you were telling, I think that's something that people do apply.
Yes.
Hygiene is important, I think.
Yeah. And
We
sits
have
bath.
to tell them not to use soap water.
Yes.
Many of them, they use it and it makes it worse.
Loose.
So it's just a plain water.
Plain water.
They can just sit and have a warm little sits bath. After that, keep yourself very dry. And after that, probably apply hydrocortisone 1% plus a local one. And any Vaselines and all also tend to, because it forms more or less a base over there. So that also maybe, yeah, very effective. And anti-itching drugs, we can give any Allegras or cetirizines because that will tend to. Anything else from the audience? I think probiotics, yes. That's a little long term. It won't immediately act. So that comes out as a follow up. Now you have managed to clean her up. Let's say we have managed to clean her up, right? She's much better today. So in long term, what is the follow up are you going to do for this patient so that we know it's recurrent? It will come back again. Okay, we have done a good glycemic control because this patient was off. We are doing a good glycemic control. What else?
But she is diabetic.
No, she's
Yeah, we did find 9.1. At that time, she was not.
She's
But
still
when Dr. Sab got her investigation, we found it is about 7. So we are going to get her glycemic control done because invariably they will be diabetic if they're coming with such a recurrent. So we've done her glycemic control perfectly done. We have immediately cured her candidiasis at present. So is there a long-term candidial follow-up would you like to go? Maybe fluconazole once a week for
we
maybe?
have to do.
Yeah. So we have to do. We can't just leave her at that. We need to do it. And what else? She's a postmenopausal woman.
Husband should also get one.
Okay, we have treated the husband. What else for the postmenopausal?
Estrogen.
Yes.
We have to examine and
Because invariably it is both the things. It's not just candidiasis or diabetes. They have a very poor vaginal health. And that is the thing that tends to stimulate them. So the main aim of this one is that you can't just leave them at that and say everything is done, you go back. You're not going to come back. You are going to come back. So
Regenerate the vaginal mucosa through PRP or CO2 fractionation.
and maybe the local estrogens on a long term would be very helpful for them. We can do that. She said probiotics, maybe probiotics also, local estrogens. And then, of course, if the vaginal health is not too great, then we can move ahead. So the main point of this particular case that I wanted to say is that postmenopausal, they may have all these infections, you treat them, but be sure there may be something that you need to take care of that.
Exactly 3 minutes for one more case. Okay? Because we can't finish without talking about recurrent UTI. So I'm experiencing my 4th bladder infection the last 6 months. The antibiotics cleared it up in a few weeks, but the burning and urgency keeps coming back. 68-year-old female, postmenopausal, and she comes with a UTI. We know all this, and each culture confirms that it is a UTI. There is E. coli, and we've been treating her with oral antibiotics. Usually nitrofurantoin works. So how do you proceed further? Do you just talk about UTI? Or do you talk about GSM?
Yes, both. We'll have to explore both the areas. Do a urine culture also to look for any resistant bacteria, look for any vaginal local infections, rule out GSM, and
So never
other.
forget that, you can't just treat the UTIs, you need to treat her as a whole. And the reason why she's getting the recurrent UTIs seems to be, you get a urine culture done, a urine analysis, and here we'll see that these are her reports. Her HbA1c is 5.4, but we saw WBCs 30 to 50 RBCs here. So how do you define recurrent UTI?
More or equal to 2 episodes in 6 months, or more than 3
In
in
a year.
1 year.
Management, acute infection treatment, non-pharmacological preventive strategies, prevention of recurrence, and follow-up. So role of local estrogen therapy in urinary complaints.
So along with the GSM, we have to find out the other reasons for UTI. There can be a stone, there can be a diverticulum, there can be urethral caruncle.
Yeah, recurrent, I think you should always do an ultrasound also, including a KUP. And prolapse and examination, of course, to see if there's a prolapse, there's a cystocele. Yes, yes. So local estrogen therapy is recommended to prevent recurrent UTIs. Systemic estrogen therapy is not recommended, and non-hormonal adjuncts, whether cranberry, D-mannose, or probiotics, may be considered.
Previously, they did not come out straight away that you can use it, but now all guidelines say that for recurrent UTIs and the postmenopausal, you can, with confidence, use these particular estrogen creams can be used. It's
And
indicated now. It's not an
also,
off-road.
also local estrogen therapy in urinary complaints should be considered for urge incontinence. So here also the guidelines say that it is recommended for postmenopausal women with urge incontinence or overactive bladder symptoms associated with GSM. In postmenopausal women with idiopathic overactive bladder or urge urinary incontinence without GSM, evidence supports its use only as an adjunct to standard pharmacological therapy. We have the other therapies. I don't think we have time to talk about them, and I'm sure there's going to be a talk rather than primary. But if we see urge incontinence with GSM symptoms and otherwise, it should be considered that it is going to be part of your treatment. She's received antibiotics, been counseled, reluctant to take local estrogen therapy, comes back 6 months later with a urine culture report showing E. coli more than 10 to the power of 5. On inquiring, she has no symptoms at all. So this was a routine checkup. You told her 6 months later, just get a urine culture and come back to me. She got the culture done as a routine check to see if it's clear. So what is this known as? And would you give her antibiotics?
Asymptomatic bacteriuria, and we should not give antibiotic in this case because it can cause drug resistance later.
So the guidelines say that in routine clinical practice, every single positive specimen is often accepted if the patient is entirely asymptomatic. But tell her that the report has come. So whether if she gets symptoms, she should report immediately because immunity is less and the flare up is possible, or if she's traveling and has less water. So at least a general treatment you should give her, but please don't use antibiotics indiscriminately if the patient does not have symptoms. The isolation of a single bacterial strain counting 10 to the power of 5 in two clean catch symptom urine specimens who show absolutely no signs of symptoms of localized systemic or urinary tract infection would be defined. So even two cultures which are positive but no symptoms is not needing treatment. So no symptoms, no antibiotics, and treating asymptomatic bacteria is harmful because it doesn't prevent UTIs. It increases drug resistance and causes adverse drug reactions. What about pyuria? So that means we are seeing white blood cells in the urine, but still has no symptoms, culture negative, no antibiotic. Will you give antibiotic?
No.
No. So I think in postmenopausal, these things are very important. Asymptomatic not to be treated, pyuria not to be treated.
We are not discussing the fifth
We are not
case.
going to discuss
One
this case at all.
one
No, but
question.
if she is not getting relief with any antibiotic or anything, then we can go
Go
for
for
lasers.
lasers, PRP.
There's one more.
That's the answer. We are regenerating mucosa.
Yes.
Otherwise, the patient goes back to square one.
And
She will get
also-
infection again and again.
Starting with the experts to all the panels. One second.
Regeneration.
I think I go with her, and then we have to get trained and do this regeneration preparation. I mean, process.
Can I ask one question only? We have a lot of patients in the village because of, I think, long term they have been suppressing that the urethral meatus becomes very pinpoint, and that goes into recurrent UTI. So that can we treat only that with estrogen only? And we need dilatation. We need dilatation. That is one where surgery has to be done.
It's not
And that
surgery nowadays.
I
It
mean,
is just an OD.
yeah, it can be done OPD. It can be done OPD, but sort of surgical interventions.
One comment.
Um, about GSM, menopause, the women have to be open. We need to help them open up to us and make them understand that it is a progressive thing. It is going to happen sooner or later, but it is highly treatable.
A little fast. They're getting very hyper.
Actually, we can start with the basic things and we can go up to lasers also. They are very helpful.
Say menopause is a natural transition, but enduring progressive physical pain is
It's
not.
not. Yes.
Every gynecologist need to know about GSM, and also the second line is lasers. Everybody needs to have that knowledge.
Yeah.
Whether they're putting it in practice or not.
We have to give time to patient for comprehensive clinical evaluation before treating them and take them in the confidence.
So I would like to say only one thing, that the first course is estrogens. Laser is not the first one. Start with estrogens. If it doesn't work, then move. So the main aim of telling over here is start being confident about using estrogens and use it freely. You may not need to go for the lasers. Thank you very much. Thank you, everyone. Thank you so much.